Welcome, everybody. According to my clock, it is 12 o'clock noon in Toronto, where I am. So I'm going to get us started today. And welcome to everybody joining this webinar. I can see that we have participants online. I'll also let you know that during the question and answer period and before the question and answer period, you can post your questions in the Q&A section of this Zoom meeting. So my name is Elizabeth Donner, and I am one of the co-chairs of Partners Against Mortality and Epilepsy. And hopefully you've heard about PAMI before. PAMI is an organization dedicated to increasing our understanding and ultimately reducing deaths associated with epilepsy. And one of the ways we try to do that is through education. And so I'm very excited today to bring together a group of people to talk about a critical topic, and that of the relationship between seizures and sudden death in children. And so let me introduce who we have here today. So at the top of my screen are Katie and Justin Fell. And Katie and Justin had twin boys in June 2021, Hayden and Cameron, and they also have a daughter. And Hayden began having febrile seizures and then so tragically died in his sleep at about 17 months of age. And I'm incredibly grateful to Katie and Justin for joining us today to share Hayden's story. So you'll hear more from them in a little while. Also joining us today, I have Laura Crandall and Orrin Devinsky. Laura is a research assistant professor in the Department of Neurology at the NYU Grossman School of Medicine and co-principal investigator of the SUDC Registry and Research Collaborative. She's going to tell you more about what that is, but SUDC is Sudden Unexpected Death in Childhood. And Laura's had a long and important career working to improve forensic science standards through her roles on federal working groups, such as the Scientific Working Group for Medical Legal Death Investigation, the Organization for Scientific Area Committees, Subcommittee for Medical Legal Death Investigation, and the National Commission on Forensic Science. And important for us today, she's been a world leader trying to understand sudden unexpected death in childhood. And it's really her work along with Dr. Devinsky's that we're here to discuss today. And that brings me to Dr. Orrin Devinsky, who is a professor of neurology, neuroscience, neurosurgery, and psychiatry, also at the NYU School of Medicine. And his epilepsy research includes a broad area of topics, but important for today and work that he and I have had the opportunity to collaborate on has been with regards to sudden unexpected death in epilepsy. He is the principal investigator of the North American SUDC, or Sudden Unexpected Death in Epilepsy Registry. And also for the SUDC Registry and Research Collaborative, he works with Laura on that. So it's my pleasure to invite Laura and Orrin to begin their presentation, just to give you a little bit of an outline of what we're going to talk about today. You know, the idea for actually bringing this topic forward and having this webinar today really came about through my discussions with my PAMI chair colleagues as we looked at the recent publications coming out of Laura and Orrin's work. And that included most recently a paper describing the video analysis of sudden unexplained deaths in toddlers. And that actually included Hayden, Katie and Justin's son. And that built on previous work suggesting that children who have febrile seizures may have some risk of unexplained death through the work that Laura and Orrin have done looking at children with sudden unexplained death in childhood and the incidence of febrile seizures in that group. So that's a really, as a pediatric epileptologist, I'm a pediatric neurologist at the Hospital for Sick Children in Toronto, and I lead our neurology and epilepsy groups here. That's a very important topic for me because we really need to understand that relationship so we can support families and counsel families. So I felt compelled to ask Laura and Orrin to come today and help us to unpack this. So I'm going to hand it over. Laura, I know you're controlling the slides. Are you starting or is Orrin starting for us? Orrin. So then Orrin, I'll ask you to unmute.
I am now unmuted. Thank you for that introduction,
Yeah.
Elizabeth.
Great. Thank you.
Laura, you want to go to slide 1? So I'm going to start out by giving some definitions, and then we will cover, just to go over where we'll be going, the SUDC Registry and Research Collaborative that Laura and I have been working on. The Fells will tell you Hayden's story. I'll review some of the information on febrile seizures and unexplained deaths in children and the implications and interventions, and that'll mainly be by Laura, with me chiming in a bit on the background. Next slide. So let's just start with definitions. Epilepsy is something which has changed definitions over time, and I suspect it will change again, mainly on the more benign end of the spectrum. So prior to about a decade ago, epilepsy was defined by 2 or more unprovoked seizures. And by unprovoked, we mean not caused by an obvious environmental insult. Because children between ages 6 months and 5 or 6 years of age are very prone towards seizures in association with febrile illnesses, that category of febrile seizures was kind of carved out probably 50 or so years ago by the neurology and epilepsy academic communities, with the goal being these occur to up to 3 or 4% of American and North American children. That percent is even higher in Asia. So you literally have millions of children having these febrile seizures. The vast majority of them outgrow it after age 5 or 6. And so it was felt to be a self-limited disorder provoked by an environmental stressor, namely illness or fever. And so it was taken out of the epilepsy classification, I think for better and worse. I think it's great that we can have parents who have kids with febrile seizures and reassure them and tell them almost everything will be fine. But as you'll hear today, that's not true for everybody. So again, the definition of epilepsy on the milder side is a moving target. So about 10 years ago, the International League Against Epilepsy changed the definition, and they decided one unprovoked seizure with either an EEG or an MRI abnormality that could be associated with focal epilepsy, where seizures begin locally in one part of the brain, is enough to make the diagnosis of epilepsy. I suspect it will change again, because these are just opinions that doctors and experts have. Epilepsy is a common disorder. It affects well over 3 million people in the US. And there are many, many, many causes of epilepsy, genetic factors, blood vessel abnormalities like stroke or arteriovenous malformations, inflammations like autoimmune disorders, infections, tumors, trauma. But in many, many cases, and probably the majority of people with epilepsy, we truly don't know exactly what the cause is. We often guess it's genetic. If it's someone who's 80, we often guess it's vascular, but we're often uncertain. Next slide. So febrile seizures are a specific category of seizures. And as I said, by themselves, they don't warrant the diagnosis of epilepsy. And febrile seizures come in 2 broad categories. Simple, generalized ones are relatively brief in duration, in that they last less than 15 minutes and they do not recur. And they do not have localizing features like only one arm convulsing. By contrast, complex febrile seizures last at least 15 minutes, or there are more than 2 seizures in a 24-hour period, or there's a clearly focal element to the seizure. And the classic definition is 6 months to 5 years of age. In some classifications, you might see this extended from 3 months on the low side to 6 years on the high side. Again, none of these are hard and fast rules, but they're very useful as broad guidelines. Next slide. So we're not going to be focusing on SUDEP, but I think it's extraordinarily relevant to the topic we'll be discussing here. And SUDEP, or sudden unexpected death. And keep in mind, the UN is different in SUDC and SUDEP. In SUDEP, we know what causes death. We think it's a seizure in the vast majority of cases. For SUDC, it's unexplained because truthfully, we don't know what causes it in the vast majority of cases. So for people with a known diagnosis of epilepsy, where there's no obvious other cause of death, they didn't have a car accident with head trauma, they didn't drown, they didn't have a heart attack or die from cancer, if someone dies suddenly, it would be categorized as a SUDEP, especially if we have an autopsy and toxicology that shows no other cause of death. The incidence of SUDEP is over 3,000 per year in the United States. Myself and many others believe this is a significant lower range, as many patients I've had who I think meet criteria for definite SUDEP were classified by medical examiners or forensic pathologists as having cardiac death, because seizures don't leave any telltale trace in the brain or the heart. But if you're 30 years old, you're going to have some degree of atherosclerosis in your heart. If you're 6'4" and you're overweight, you're going to have a larger heart than average. And those things could lead a medical examiner to call it a cardiac death when I believe it's an epilepsy-related death. What can we do to lower the risk of SUDEP? And I know this has been the topic of many PAMI webinars. We can control seizures, either with medications, surgery, neuromodulation, and probably most importantly with lifestyle. If you're prescribed anti-seizure medications, or your child or loved one is, to take those medications as directed, to get good sleep, which means probably for adults a minimum of 7 and ideally 8 hours a night, and kids often need more. To be very careful about disruptions in circadian day-wake cycles, since if you fly, for example, from New York to Hawaii and get 6 hours, 7 hours of sleep the next night, you'll be at much higher risk of a seizure because your circadian clock is so disrupted. And then finally, excess alcohol, not typically while you drink, but 6 to 48 hours after you stop drinking is when your nervous system will become hyperexcitable. Many of us from college know that as a hangover, but for people with epilepsy, that would be the perfect time to produce a larger seizure. And Laura, I think, yeah, so my last slide is this one. And this just highlights some of what we do know about SUDEP. So this was from an earlier study by Philippe Revlan, which was really a landmark. They looked at about 11 sudden unexplained deaths in epilepsy that occurred in epilepsy monitoring units. They actually had a video and an EEG of these tragic deaths. All of them followed tonic-clonic seizures, which is typically what happens in SUDEPs that are witnessed outside of the hospital as well. And what we think happens with a seizure is that during the post-seizure state or post-ictal state, there's a shutdown of brain functions. And if you shut down the brain, you shut off breathing. Remember, your heart can go without your brain, your lungs cannot go without your brain. So probably we think respiratory arrest or decreased breathing is the primary outcome, but secondarily, the heart can be affected, and probably in some cases, the heart may be a primary area. The other thing that happens after a seizure is that the entire nervous system, the brain, is in a partially shut down or potentially completely shut down stage. And one of the other things the brainstem does, in addition to controlling breathing and respiration and cardiac, is that it also controls arousal. And so if I were to come up to one of you in the middle of your sleep at 3 a.m. and go into your bed, or not go into your bed, but take my knuckles and put them into your sternum gently and then keep exerting pressure until it became painful, you'd wake up and fight me off. But if I took a baseball bat and hit your head and knocked you into a coma, and then I did this with my knuckles, you would be completely unresponsive. And that's what some of the fears of SUDEP is, that the brain's essentially in an off position. Now, I should mention, after that originally study was done, Sam Latu, another major researcher in SUDEP, published a paper in Epilepsia, where there were 3 cases captured in epilepsy units that were due in people with epilepsy, but they were not associated with any clinical or EEG changes of a seizure. So SUDEP typically occurs after a big seizure, but not always. Laura?
Okay, so I think I'm going to give you a break now, Orrin, and just talk about a few more definitions. So when we talk about sudden unexplained death in the young, we're really talking about this wide age range from birth throughout childhood, which most people define as 18 years. And within that, if you look at the bracket between birth and 12 months, that's the period of infancy. And we talk about unexplained deaths in infancy, or SIDS, as many people will relate to and know that. But if a child dies suddenly and inexplicably after the first birthday, we did not have a definition for what to call those deaths. We published one in 2005 as sudden unexplained death in childhood, being the unexplained death of a child between 1 year or 12 months on or after their first birthday throughout 18 that is still unexplained after a thorough investigation, where a specific cause of death cannot be identified. And when we look at the statistics around this, we see the majority of those are happening in children between the ages of 1 to 4. So about 60% of all of those unexplained deaths between 1 and 18 are happening in those children in the toddler years, which, as Orrin just explained, we also see overlaps with that age risk for febrile seizures. We see a slight bias towards boys, which is common in many diseases in early life. And most of these deaths are unwitnessed and sleep-related, although they don't have to be. The most recent data that just came out in terms of our leading cause of death charts, if you looked at it in the group of toddlers, you would suspect that these unexplained deaths are not really a public health problem. The issue is that right now, the US leading cause of death charts do not pull the data for deaths that are unexplained. For ICD codes, there's ICD code R96 to R99. Those are ill-defined or undetermined deaths. If we did pull those and add them to the chart, unexplained deaths in children ages 1 to 4 would actually be the 4th leading category of death in children. And I think that is one of the big problems with researching this area, is that it's just not well known because we're not reporting it. So if we go and look at this kind of all together, we see how there's these overlapping diagnoses and categories of death. Epilepsy, which does not discriminate by age. Febrile seizures, which runs between, we consider that mostly between 6 months and 5 years. And then unexplained death in childhood. And again, we see that really strong overlap between the majority of SUDC and where the majority of febrile seizures are occurring. So Orrin and I met over 10 years ago, maybe 12, 13 years ago, and I came to him with this question about febrile seizures because at the time we had the SUDC program with, I think, 600 families registered. And about 25 to 30% of them reported that their child had a history of febrile seizures. And so I went to Orrin and we discussed this, and we decided that we were going to create this new registry called the SUDC Registry and Research Collaborative, with our goal of analyzing 400 cases of SUDC to try to understand their underlying causes, identify risk factors, and of course, develop prevention strategies. We have many collaborators at the registry across the United States as well as abroad, with many publications. We have already enrolled over 370 cases, so we're getting close to our initial goal set. And if anyone has any more questions, they can visit the website at sudc.org, where I think almost all of our publications that we published are open access, so you can have easy access to seeing them. But our approach to these deaths at the registry is the child is central. We enroll these children through their devoted parents like Katie and Justin, who really want to be a part of learning more through these tragedies so we can prevent it in someone else. And we collect a lot of information about those children through their medical records, genetic analyses, and all of that data that we bring together enables these even more higher powered evidence-based studies that you can see in the purple bubbles outside. So this is kind of a quick overview, but there's a lot going on and really continuing trying to answer those research questions. So what I'd like to do now is turn it over to Katie and Justin, if you could share with us and share with everyone here about Hayden. And again, thank you so much for being here and everything you do to support research.
Absolutely. Thank you, Laura. And thank you, everybody, for allowing us to come to you. Like many parents and people out there, SUDC really wasn't on our radar until, it happens to you. And the hopes of speaking to you today, you can carry it on to other parents and just be a little cautious. But back in June of 2016, we welcomed two boys into the world, Hayden and Cameron. And it was a happy sleep deprived time of our life, in which things went normal for almost a year. And the week before Hayden and Cameron's first birthday, I remember being on a conference call with my team and hearing somebody scream my name to come down and find Hayden having his first febrile seizure. And we headed to the ER, talked to multiple health professionals and took him to his pediatrician and really started to talk about febrile seizures and hear that this was something that children go through. Over time, it's not something to worry about. Diving into our family history, Katie had febrile seizures as a child, and I had early childhood epilepsy. So we're both here, and we really just were told to watch them as they happen, stay with the child, some safety precautions. We live a little, say, far away from a nearby hospital, so anytime that Hayden would have a febrile seizure, we would call and have medical professionals here and then get him to a hospital or get him seen as soon as possible.
And there was really no reason for us to believe anything than what we were being told, which was, based on my own personal experience, based on Justin's personal experience, that he was going to be a happy, healthy little boy. We were just going to have to deal with these seizures until he grew out of them. And he had multiple seizures. He had a total of 5. And because of our histories, and especially Justin's medical history, we found a pediatric neurologist at Kennedy Krieger, who's affiliated with Johns Hopkins. We're from Baltimore. And we just did it truthfully, like to kind of ease our minds and make sure we were doing everything we possibly could for Hayden, because that was what was most important to us. And, he gave us the same information that pretty much the other doctors did that we spoke to in the ER, his pediatricians. And I even specifically asked him about seizures in sleep. And he told me not to worry about it, that he would be fine. Like, many people have hundreds of seizures in sleep and they don't even know it. And they wake up the next morning and everything's okay. But that ultimately wasn't what happened for us, unfortunately.
Yeah. November 27th of 2022.
Yeah.
I walked into our boys' room to find Hayden unresponsive. From there, I hate to say, our house turned into a crime scene. We were isolated. We got Cameron out of the room. Our daughter was whisked over to another side of the house with her grandfather, and it became every parent's nightmare. So, once kind of the dust settled from that, within about, I'd say 48, 72 hours, we were put in touch with Laura through a family friend. And, we started down the path of, learning about SUDC, going through genetic testing. And, really just suffering through the loss of our child.
I know that I actually think I was looped in with Laura 24 hours after everything happened. And I sent her a long rambling email with Hayden's entire medical history, because we had a video of the night that Hayden died, and we knew that he had a seizure. So I knew that this seizure was critical as to what ultimately caused his death. And I knew that he could teach someone something. And we wanted to do everything we could. I'm sorry. We wanted to do everything we could to not only help another family or prevent another family from having to go through what we've been through and through the hell that we've been dealing with and have dealt with, but also to do something good in Hayden's name, which has become something that is very important to us. Sorry. And again, by the end of that first week, we had fully enrolled Hayden into the study. We had, Justin had gotten the video over to Laura of the night that he had died. We had donated Hayden's entire brain to the study to be analyzed. And we had also enrolled ourselves in the study so that we could not only genetically test Hayden, but also genetically test ourselves to see if there's anything that we missed that could have been prevented. And everything came back for all of this completely normal. The only clue that they really had was the seizure in the video. And so that is why Hayden was a part of this paper that was just published this last January, where they studied a few videos of children who had passed. And I know, and I'm sure Laura and Orrin will speak to this, but a majority of those videos showed these children having seizures immediately before their deaths. So this is obviously something that we want parents to know is a possibility. When you go and you speak to your pediatrician, the ER doctor that's helping you through the first febrile seizure that your child's dealing with, it's not to scare parents that this is, going to happen, but I do think that they should know that it's a possibility that it could happen. Because if we had known that there was even the slightest possibility that this could have happened, we would have taken more extreme measures and ways to monitor him in his sleep. But unfortunately, that isn't the guidance. That wasn't the information that we were given. And we were, we did everything that we could. We did everything that we were told to do. We tried to follow everyone's instructions, and we felt like we did everything that we could have for Hayden at that time.
I think, Katie and Justin, I just want to take a minute to thank you for your strength and bravery and honesty, and willingness to talk about this, your collaborations with Laura and Orrin, so that we can come to learn more and understand more. So thank you for that today, and for being here. And if it's okay with you, I think we'll move back to Laura. Is there anything else you want to share before we do that? There's no rush. I just wanted to make sure you didn't have anything else.
Just thank you for having us and for letting us tell Hayden's story.
Absolutely. Those beautiful pictures of him and your family. Those are great. Thank you. So we're going to move back to you, Laura,
Okay.
to try and kind of get at this relationship between febrile seizures and SUDC, which is so complicated because, of course, febrile seizures are very common, and thank goodness SUDC is quite rare. So how do we kind of put that together? Well, that's easy for me to ask a question. Up to you to try and figure it out. Yeah.
Well, I think that's what we've been working on for quite a long time. And again, I think we've made some progress, but we still have a lot more answers. A lot more questions to answer. And again, thank you for Katie and Justin. I mean, none of this work would have been possible without courageous parents like them really coming to us saying I want to help. But just a little bit of review of some of the research that has been out there. This association of febrile seizures and sudden child death, we first published that it's just since 2005 when we published that same paper that defined sudden unexplained death in childhood for the first time. And that was the first period where that's what pulled out of the data. And we were quite surprised at it in those first 50 cases. And we thought maybe there's some bias going on here. Maybe we're just collecting those types of cases in a disproportionate number. And the more cases we review, maybe that number will go down. But you can see several other publications on here in 2012, 2015, going forward that we still keep seeing, 20 to 35% rate of febrile seizures associated with rare types of death. Unexplained child death, if we go back to those leading cause of death charts, even though it's the fourth leading category of death in children age 1 to 4, that still amounts to 1.9 cases per 100,000 children. It's quite low compared to many other disorders. So there is that really complication of studying something like febrile seizures, which is very common, against something as a very, very rare negative outcome. So from there, I'd like to mention another paper that we did in 2019, where we looked at 391 family interviews that we did with families who were registered with the SUDC Foundation. And we asked them what their child's final cause of death was categorized as. And it broke down to about 264 of them were unexplained and 127 were considered explained by the text written on the death certificate. And again, we saw this 29% rate of febrile seizures among the unexplained deaths. But what's surprising for us, and I think this might have been the first time this was recognized in the literature, we also saw 22% of febrile seizures associated with sudden explained deaths. And again, this probably has to do with variations the way death investigation systems work, but called to attention. At the SUDC Registry here at NYU, when we looked at our first 100 cases that we reviewed, 77 of them were unexplained at the end of the multidisciplinary review process. So those other 23, many of them were explained. But based on the guidelines we helped develop with the National Association of Medical Examiners, when we categorize these deaths, we also use descriptions for intrinsic and extrinsic factors. And those are things that, for the pathologists, they say it kind of sticks in my head that this child had adenovirus or they had some other changes. But these are the kinds of factors that in and of themselves, they don't rise to the level of evidence to say this is what they died of. But we list them as these factors so that we can track them for research. And so this graph that you see in front of you shows what those factors were on those first 77 cases. And you see that the immunological or infectious factors, so either the child had signs or symptoms of a mild illness, or there were signs mild pathology associated with infection and autopsy. We saw that almost over 58% were found prone face down. This was very intriguing from a scientific point because these are developmentally children who are walking, talking. I say, they're more likely to get hurt climbing out of their crib and escaping than they are from being prone face down. So developmentally, that was something that was quite striking. And then if you look over to the neurological, the majority of these are febrile seizures in those children. So last year, we worked to do a systematic review, which is a review of all the literature, trying to understand of all the people who have studied a topic, what information exists. And we looked throughout the literature, And the majority of febrile seizure research, of course, is not associated with these sudden deaths, because we know the vast, vast majority of febrile seizures, the children do grow out of them. But the sudden death registries that focus on that tiny minority of febrile seizure cases do support that simple febrile seizures are rarely associated with increased mortality risk. And so this was an important review for us to, again, say there's this question out there. If there are these rare associations with mortality, and we have the current clinical recommendations for febrile seizures as they are, how can we identify those specific children who might be at a higher risk that we might want to do something different with going forward? Most of those publications that I mentioned are from different registries. The largest population-based study on febrile seizures and mortality was done back in 2008 in Denmark, where they studied over 1.6 million children born, followed them up to 28 years. It was from 1997 to 2004. They looked at the records, and they did find an increased rate of death among children with a history of febrile seizures versus age-matched seizure-free children. And when they looked even more specifically at what those children died of, they did see an increased mortality rate risk among children with a cause of death of seizures, which that doesn't surprise probably anyone at PAMI. But I did want to point out that the 11 rate for sudden unexpected death, that wasn't called out too highly in the paper, but those are those R96 to R99 codes that the sudden unexplained death and childhood deaths would fall under, those ill-defined causes. So I think you really have two kind of markers from this study of increased risk. And what they found was that there was a 5 times risk of sudden unexpected death in the 2 years after the first febrile seizure. But when they did the nested case control, it was really only associated with complex febrile seizures, when we see simple febrile seizures in SUDC. So again, a further complication to really weeding this out. So a couple people have mentioned the recent publication that that came out in January of this year, and that Justin and Katie also identified. And this was a video analysis of sudden unexplained deaths in toddlers. I first want to say, I understand everyone listening to this. This is even hard to think about. It is hard for clinicians and families to think about that this information was captured on video. It's also incredibly scientific important and has been extremely valuable to us. What we did was we studied 7 videos that we received. These were all young children between the ages of 13 and 27 months. They all had normal development through their medical records. Just one had a history of febrile seizures, which you already know who that is. The circumstances were all sleep related, and a few of them did have minor recent symptoms. They had a cold, they had a cough, they had a diaper rash. Maybe they had a little bit of teething, very, very minor common childhood elements. And these videos were in 2 different categories. 5 were continuous, meaning the recording just played and played. 2 were triggered by motion or sound. So if the child moved or if the child made a sound, then the camera would record, otherwise it did not. The results with this, the 2 that were motion and sound triggered, it was because of the time gaps, it was difficult to assess really what was going on. 1, there was just no movement that we could see that was suspicious, but 1 seemed to have a convulsive event we suspected, and it looked like we just missed it possibly. But of the 5 continuously recorded videos, all 5 of them, we identified a convulsive event. And this was not based on one person's opinion. This was based on 7 different physicians. So we had a group of forensic pathologists who are usually the medical examiners charged with investigating these deaths. And then we also had 2 clinicians, Dr. Devinsky as a pediatric epileptologist, and then also Dr. Rodriguez. These convulsions that we saw in the videos, they were all brief. They were less than a minute. And 4 of those 5 were known to be alive at least 2 minutes after. So similar to what we see in SUDC, the person is still seems to be alive at the end of that convulsive period, where we're seeing the deaths more occur in the post-ictal phase that Elizabeth spoke about. And I also wanted to note that we did genetics on all of these children, and we did not find any significant findings there. So in conclusion of this small series that we did, it was finally evidence from the room that we have just never had with sudden unexplained death in childhood cases. We think that maybe the mild infections that the children had may have lowered their seizure threshold. And we know, Elizabeth and Orrin have both talked about during that post-ictal phase, how our arousals and our reflexes are different. And whether that suggests some common mechanisms between SUDC and these SUDC deaths. While we can't rule out primary cardiac mechanisms as the primary reason of why the seizure occurred, we think it's less likely. 1, because the children had no history of any cardiac problems, their cardiac pathology from the autopsy was normal, and also the genetics were unremarkable as well. These cases that the parents offered the videos were also incredibly important because without them, there would have been nothing on their autopsy that would have implicated the seizures. Before we go on to the next stage about talking about monitoring and febrile seizures, Orrin, is there anything else you would like to add about this paper and where we're at?
I would just add, Laura, that I think, two things you showed, this paper and then the explained deaths. So I must say, of all the things Laura and I found in the last 12 years working together, the first one was that febrile seizures occur something like 10-fold more frequently among SUDC cases than the general population, which got us started on our collaboration. Then when we did that study comparing explained versus unexplained, so the unexplained are the SUDC, and we kind of knew that febrile seizures are much more common in those kids. But keep in mind, the average American child between ages 6 months and 5 or 6 years has a 3% chance of having a febrile seizure or more than one febrile seizure. So now we have kids with explained deaths. So these are kids in which a medical examiner said pneumonia caused the death, drowning caused the death, something caused the death, heart disease caused the death. The percentage, was it 20%, give or take, Laura? You can remind me. I forget, but it was at least 6-fold higher than the general population. And so what that suggests to me, and we've seen this before, Laura had a meeting mainly with medical examiners at a hotel near JFK about 7 years ago. And I'll never forget a mom there who I'd never met before, who lost her young child tragically to an SUDC spoke. And she said when her child died and went through all the horrible things of, being investigated by the police, having a complete autopsy and forensics done on her child, the medical examiner came back and said the child died of bronchitis. And the mother was flummoxed and said, I don't understand it. My child, had like a cough and barely had a fever when they went to bed. And you're telling me that they died from a pulmonary infection. Yeah, so it's 22% of the explained deaths. So this mother was told your child died from bronchitis, and she challenged the medical examiner like, that makes no sense to me. Was it that serious that it would kill my child? And the medical examiner, as she said, admitted, well, no, I had to put something down, and I didn't want to say I didn't know, so better to put something down. And I think that's a bias all human beings have. None of us, patient comes to me and says, what's wrong with me? And I may say it's a seizure, and then they'll say, why? They don't like to hear, I don't know. It's not a satisfying answer for them to receive. It's certainly not a satisfying answer for a physician or a medical examiner to deliver. But I think it's critical in science that we be honest. When we don't know, we have to say we don't know. So I think there's an incredible tendency to say we do know when we don't. And in America, that usually goes to cardiac or pulmonary causes of death. And so I think we underestimate these. So I think the importance of the monitoring study is of the cases that died. I think the Fell's child was the only one who had a history of febrile seizures. The 5 cases that clearly died from a seizure, only one had a history of febrile seizures. So they would have come up as ones in which we wouldn't have even vaguely suspected seizure as a cause of death. It wouldn't have been on the list of, never mind probabilities, possibilities. So I think this study for me is a huge eye-opener and says to us that seizures may be a far more common cause of death in children, in adults, in people with histories of epilepsy, and people without a history of epilepsy. And I don't think we'll ever know what that true number is because medical examiners don't even think about it. If a 30-year-old man dies suddenly, like I said, they'll do an autopsy, even if without a history of epilepsy, clearly epilepsy would never come up. So I do think we're underestimating the true frequency of SUDEP and SUDC, and more importantly, seizure-related deaths across all age groups.
So,
yeah.
Oh, sorry, Orrin, thank you very much. Well, I have a lot of questions, and I know we have more to discuss. I just one question just about what you just said, though, just to like frame the discussion a bit is, so are you suggesting, because I think you and I both have a fair bit of experience working with medical examiners and re-reviewing causes of death and stuff like that. So are you thinking that these the ones that were said to be explained weren't necessarily, the explanation may have not been the only cause of death there? Is that kind of where you're going with
That's
that
exactly
thinking?
right.
Yeah,
I think
okay.
since
Yeah,
the
so
rate
they maybe
of
wouldn't be, it depends who classified them, whether they'd be called unexplained or explained.
correctly. So
Okay,
think about
yeah.
the denominator,
Yeah.
there's 7-fold higher rate of febrile seizures in the explained
Yeah.
causes. Now think about how many cases that have febrile seizures, but the parents in another room and the kid's watching a video and they come back and the kid's sleeping and they say, oh, kid's taking a nap. And the kid had a febrile seizure, and the kid's sick, they would never know. So anyway, we don't know what that true number is, but I suspect it's
Okay.
far. So
And
let
then,
me, yeah, go ahead.
I just, as we go into the discussion, or were you going to talk about monitoring now?
I am, yeah, the next
let me
piece.
frame that discussion a little bit,
Yeah.
because obviously, and I really liked your paper, kind of looking at the systematic review and trying to understand about this relationship. And one of the things I liked was that you really pointed out in that, both of you were authors on that paper, that we need to, find a way through public health to balance recommendations, because febrile seizures are common and SUDC obviously is rare. And I think the other thing we need to really acknowledge is that for those of us working in this field, we're familiar with the recommendation that for sudden unexpected death in epilepsy, particularly for people who are having nighttime seizures, nocturnal seizures, that some kind of nocturnal monitoring is recommended when feasible. And it's not always feasible to do so based on family circumstances and that. But at the same time, I think we also recognize that devices have not been demonstrated to save lives, and that sometimes they can make people's life a little worse, right? By disrupting sleep and even maybe giving false sense of security. And I think for families like Katie and Justin, it's important to recognize that, monitors aren't necessarily going to save a life. So how do we do that? I just wanted to put that context in there to make sure that we don't leave this thinking that the answer is going to be to monitor all children, because I'm afraid it's not going to be the only answer.
No, I completely agree, Elizabeth. So this slide just highlights that while febrile seizures are very common, 3% of all kids is a big number. Among US kids with febrile seizures, obviously it's a much smaller because we're a small portion of the world population. But of those kids, and you can find pediatricians in the general practice, and they'll say, oh, I see febrile seizures, once a month or, even more frequently. But I've been a pediatrician for 35 years. I've never seen any deaths. Now, number one, they may not know a death was related to a febrile seizure, but even with that, there's a good chance a pediatrician can go through their entire career, see 500 kids with febrile seizures and never have heard about any kind of death related to that. So it's a tiny group of that. And that's what makes the public health implications like monitoring very challenging. Next slide. So these are the risks, and I think Elizabeth framed the discussion. There are, millions of kids at risk. The number of deaths is in the low hundreds, and it's a balancing act. So, just to put this in perspective, I just had a call with a woman and her son in California. He's not a febrile seizure case, but he's a little similar. He had 2 seizures in his life. They were both convulsive. They both occurred in sleep. He had a routine EEG that showed generalized spike wave discharges, so he meets criteria for epilepsy. And as soon as the EEG came back, a pediatric neurologist who's not seen the child or the parents yet called up and said, you need to start Keppra immediately, which of course the mother and father looked up and said, no way, Jose. So it speaks to the 2 worlds we're dealing with. I think for the parents, like Justin and Katie, who have had this, and Laura, who have had this unimaginable tragedy, and I know many in the SUDEP community in the same boat, it's like, why didn't people tell me? I would do everything we can. And yet here's a family, and I did go through, the possibility of a sudden death in this child with 2 nocturnal seizures. And all she was focused on is, I don't want this to interrupt his life. And that's a very, understandable. She's a wonderful mom, and it's a balance. So I think as we can monitor every kid, but number one, I did this at a group home in Massachusetts where they had a death, which just devastated them, of a young adult with developmental disabilities. And they ended up getting monitors for everybody with a history of seizures in that, large group home with several hundred people. There were probably 30 with seizures. And they got a wristwatch monitor for all of those people. They called me a month later that they had another death. I said, oh my goodness, was the person wearing the watch? They said, no, he didn't like the watch, so he took it off when he went to bed. And this is the issue that, Elizabeth is touching on. It's the same thing. We can get an oxygen monitor, but if the 4-year-old kid keeps pulling it off at night, it's not going to do it. And the parents are going to get woken up because it's going to go to 0 oxygen. Parents are going to go running in at 2 a.m. Their heart's pounding, thinking their child's dead. And meanwhile, the kid just is a finicky sleeper. And as many of us wouldn't want something on his hand or his wrist or his toe. So I think it's a balance, and I don't have the right balance, but I do think parents deserve the opportunity to know and make an informed decision. I think that's the only thing we can do. But I think by the same token, saying we have all the answers or that everyone's got to do it is probably not the right thing. Laura? So SUDEP risk reduction strategies similar for febrile seizures. I think they're similar but different. SUDEP risk reduction, especially, we know 2/3 of them, give or take, occur during sleep. And so that's a high risk period. It's an extraordinarily high risk period for SUDC and what we think are probably febrile seizure related deaths. Sleep guidance for infants under 12 months are clear, alone, on their back, in a crib, pillows, etc. And then for children over age 12 months, I don't think we have criteria either at a public health CDC level or at a scientific medical level, but I think we need to develop them and need to think more about them and need to find minimally obtrusive ways to potentially monitor these kids that could potentially be life-saving for the very rare child. Next slide. And so for the parents who want to learn more about monitoring strategies, the Danny Didd Foundation has a great website on this. There is research on SUDEP monitors to a limited degree. I think there's no real studies ongoing about febrile seizure monitoring. The technology is evolving. Very few of them are approved for very young kids, and none of them are shown to be effective, as Elizabeth mentioned, for reducing SUDEP risk. Many of them are pretty darn good at detecting convulsive seizures, but no one's been able to prove that they actually reduce SUDEP risk. And then there may be ways with, cameras that can detect abnormal movements. We hope with AI, this will get better and better with time. Infrared can certainly help in sleep. And as I said, wearable watches are good for older kids and adults, probably not for the very young kids. And then alarms like oxygen, we do think the final common pathway for SIDS, SUDC, SUDEP related deaths is probably a cessation of breathing. So an oxygen monitor would be ideal. The problem is they fall off, they can be pulled off, they can come off during sleep. And again, you can't have parents waking up 4 times a week for something that may never happen over the course of 10 years. So it's a balancing act. Laura, I think it's back to you.
Thank you so much. Really, I just wanted to share just 2 resources for those on the line. We talked about guidance for investigating unexplained deaths in pediatrics. If this website, sudpeds.com, does have the book that Orrin and I and many people were involved with publishing, the national recommendations. It is available on the NCBI bookshelf for free, so it is open access online. And then there's also the webinar that was developed from the book, and there's a link to that on the sudpeds.com site. And this is meant for all professionals involved, including pediatricians who are caring for families after the fact. And then finally, just a shout out to our team of everyone working on the SUDC Registry and Research Collaborative, and all of the funders, and of course the bereaved families who make all of this possible through their tragedy of and working with us to try to bring about a brighter future. So thank you all. Thank you for having us.
Thank you. Thank you so much. I'll ask you, maybe you can even stop sharing your slides so that we can see faces, and that's great. Thank you. And I invite people to post questions in the Q&A section of the webinar. And I see that we have some questions there, and we'll go to those now. So okay, let's start with that. So Ryan is asking, given the growing association between seizures and sudden death of all types, we know that currently we're working with an incidence for sudden unexpected death of about 1 in 1,000 per year. What do you estimate the rate of sudden deaths in which a seizure is a contributor would be? I would have my own way of answering
I'll
that
just
as
throw
well.
my
I'll
own
throw
guess
that out
out
to you
there.
guys.
I would
Yeah.
double that number, would be
Yeah.
my guess. I don't think we know the true
No.
number because it's so hard to diagnose a physiologic disorder like a seizure. So no one knows. I think it's much higher than 4,000 per year, but how much higher, I don't think we know.
Yeah. I don't know, Laura, if you want to add to that. I don't know that we could come up with an answer necessarily, Ryan. But I think what's important is to be thinking about that, you know?
Yeah. I think the only thing I would add on is that when we looked at the 7 children we studied, or the 5 children that had documented seizures, and we compared it to all of the children in our registry, they were similar. They didn't seem to be outliers in some way regarding their medical history or things like that. So we do think that it is probably much higher than that. We just don't have videos to support it.
And of course, the SUDC definition for incidents, like that's specific to people having been diagnosed with epilepsy. Those of us review those cases, we are relatively strict about it. And it means that the person had epilepsy, which means they've at least had 2 seizures before, or 1 seizure and some other tests in that to suggest they had epilepsy. So rates of death in people associated with seizure are definitely going to exceed rates of SUDC, given the formal definition of SUDC. Greta's asking a good question. And so Laura and Orrin, how has the medical examiner community reacted to this data about febrile seizures? And then just specifically, maybe to clear up, is there anything we can look for on autopsy to help with whether the person had febrile seizures? Not really, right? About autopsy. Maybe if a seizure occurred, you can find signs that a seizure occurred sometimes based on whether the person had bitten their tongue or how the body was found. But what do you think about the medical community? Have they been feeding back some information to you about all this?
So, I mean, I've been working very closely with the medical examiner community for many years. As you saw on our team list, I think we have about 15 or 16 different forensic pathologists working with us. I think they see this as very, very important. I mean, they are the ones on the front line who have to call the families when they do admit that they don't understand and tell them that, which, as we know, is really hard for human beings. So they have been very supportive. I'll be speaking about this again at the National Association of Medical Examiners meeting, which I try to attend every year to keep them up to date on all of this. So I think they're watching it and hoping that we continue to find something that will help them diagnose better at autopsy, because right now they're soft findings.
And you know, I think that the collaborations between the epilepsy community, between your group, Laura, between SUDC researchers and medical examiners has been growing, and it's been very, very valuable. So
Yeah.
I feel very positive about that. I see Jackie asked a couple questions. Katie and Justin, I know you had mentioned that Hayden had been seen by a neurologist before in the past, right? You guys had worked with a neurologist, yeah.
Yeah, so he had a childhood or a pediatric
Yeah,
neurologist at
neurologist,
Krieger,
yeah.
and then we also saw a neurologist at Hopkins when we went down there to the ER on one of his visits.
Yeah. And then just for you, Laura, I see Jackie was wondering about how to register with research studies, and you put that slide up, but maybe put that slide back up or something so that people can see the resources, because I think that's really important. And we're just about out of time. And one last question, it's a good way to end. And Orrin, you kind of addressed this, but I'll give you one more chance to kind of, do you think our guidance about febrile seizures is going to change? It's so
don't think
tricky.
it's
We've discussed this.
Yeah, the problem is it depends which side you look at it. If you look at it
I
from the
know.
sudden death community side, it has to change. It's terrible. If you look at it from the general pediatric side, there's no way I can convince a pediatrician, get 20 of them in a room and none of them have seen this over 20 years, to change their behavior. So this is the problem with a lot of things. It's like, listen, Elizabeth, in America, it's a 1 in 7,000 chance of dying every year in a car accident. If I tell that to people who live in the suburbs who need to drive to pick their kids up and go to the supermarket, no one changes their behavior. It's hard.
Yeah.
It's a challenge.
I am really grateful for your pragmatic approach to this, and recognizing that there's not an answer. Of course, I'm looking at Katie and Justin, and I'm heartbroken for them. But I think I'm also realizing we just don't have the answer yet. Thank goodness for Laura and Orrin's work. I think there's still a lot to learn. Sorry, guys. I think you agree with me, though, that there's still ways to figure it out. And to Katie and Justin for sharing their stories so that we're talking about it. And it's 1:02, so I'm going to end it there. Thank you so much to everybody who joined.
Thank you, Katie.
I encourage you to check out our PAMI website for more resources about sudden death and its relationship with seizures and epilepsy. And have a good afternoon. Thank you.
Thank you.